Hello everyone, I'm Siti Nurul Komaria from Cervical, Indonesia. Selamat pagi, good morning, good afternoon, good evening, and a very warm welcome to all our viewers joining us live on LinkedIn from across Indonesia and beyond. Every year, thousands of Indonesian families are affected by cervical cancer, a disease that is almost entirely preventable. But today, we are here to just talk about the burden. We are here to talk about the breakthrough. Our session today is titled Empowering Women, Strengthening System, HPV DNA Self-Sampling for Indonesia Cervical Cancer Elimination Initiative. We are standing at a turning point where innovation meets policy to save lives at scale. As many of you know, the Ministry of Health Indonesia is currently transforming our healthcare landscape through the Integrasi Layanan Primer, or primary healthcare integration. A massive part of that vision is making screening accessible, dignified, and highly accurate. That is where HPV DNA self-sampling comes in. It is a game changer. It shifts the power into the hands of women, removes the barrier of fear and logistics. During this session, we'll be looking at the real-world data coming out of East Java implementation research, how we maintain gold standard lab quality while scaling up, and most importantly, how this model fits into our national roadmap for cervical cancer elimination. Before we dive into our first topic, I want to remind you that this is an interactive session. Please drop your question, thoughts, or even a hello from your city in the chat section. We will be taking your question live toward the end of the hour. You can write your question or comment in Bahasa Indonesia if it is more convenient for you, and we will translate for the panelists. To help us navigate this transition, we are joined today by a powerhouse panel of experts, policy leaders, and partners who are the architect of this change. They include Dr. Siti Nadia Tarmizi, Master of Epidemiology, the Director of the Non-Communicable Disease Directorate, the MOH, Dr. Indra Yul, a distinguished obstetrician and gynecologist representing Indonesia Gynecology Oncology Association, or HOGI, Ibu Marijen Lakos, the Country Director of Cervical Indonesia, Dr. Parag Bamre, the Technical Lead for Women Cancer at Cervical, and Ibu Yulia Widyachanti, Laboratory Specialist Cervical Indonesia. So without further ado, let us start our session today. It is now my great pleasure to introduce our first panelist, Ibu Marijen Lakos, the Country Director of Cervical Indonesia. Bu Marijen will be walking us through the groundbreaking HPV DNA pilot project in East Java Province. Her presentation will provide a deep dive into Cervical specific roles within the study, the real-world challenges the team encountered in the field, and the key recommendations emerging from the project. Crucially, she will also share Cervical vision for the future. Specifically, how Cervical plan to support the scale-up to contribute to the national cervical cancer elimination plan goals. Bu Marijen, we are delighted to have you with us here. The virtual floor is yours. Please, Bu Marijen.
Thank you very much, Bu Nurul. It's my pleasure to be part of this panel today, speaking about a topic that's very, very close to my heart. So the Indonesian Ministry of Health launched the National Cervical Cancer Elimination Plan in late 2024, while it was also in the process of piloting HPV DNA testing in 16 provinces of the country. In terms of screening, the national plan has very ambitious targets, aiming to reach 75% of all women aged 30 to 69 with cervical cancer screening by 2030. And the plan calls for phasing up screening from opportunistic to population-based screening, and also calls for exploring innovations in screening, alternative strategies such as point of care screening and self-sampling methodologies. So Cervical had the privilege to recently work with the Indonesia MOH to address some of these calls for action in the national plan through introducing HPV DNA testing for cervical cancer screening and thermal ablation for treatment in East Java, which was one of the provinces not currently under the ministry's pilot. That was done with support from Roche Diagnostics and Biopharma, which is a local manufacturer here in Indonesia. And the objective of this study was to generate evidence on use of multiple screening approaches to determine how best you can support population-based coverage in a country as large and diverse as Indonesia in terms of geographical contexts. So some key characteristics of the study, we wanted to make sure that we were aligned with the primary healthcare program, as Bu Nurul mentioned, Integrasi Layanan Primer, and integrating screening within existing systems. We didn't want to set up a completely different structure. We wanted to make sure we were taking a population-based approach in line with the National Cervical Cancer Elimination Plan and aim to reach 75% of the target population in a given catchment area. We also wanted to test out implementation of the hub and spoke model, which is recommended in the ministry's national cancer plan. And then finally, and most exciting for me personally, was introducing self-sampling as an option for women for screening for cervical cancer. So the study was implemented in a relatively short period of time, 7 months or so, introducing 2 different models using a hub and spoke approach. So in Surabaya City, as the hub, we integrated self-sampling into provision of services, and it was through a fully automated platform. This was testing for a larger, more urban population in the city, Surabaya City. Whereas in Sidoarjo district, a more rural location, we applied the spoke methodology, which was provider sampling, included provider sampling, and a semi-automated system for a smaller, more rural population. So we were looking at what systems could work perhaps more effectively in a high population setting versus a lower population setting, and what that meant for lab and all of those things. But in both settings, we worked with the MOH to mobilize communities. So there was a very big emphasis on community education and mobilization, working through trained cadres or community health workers who were absolutely critical to this project. We worked to improve the capacity of providers for HPV DNA screening, where there was provider sampling, as well as thermal ablation treatment, the skills for that at the Puskesmas or health center level. We supported laboratory readiness in both settings, making sure that lab personnel were trained, that SOPs were in place, that the labs had the right equipment. And then, as I mentioned, with the thermal ablation, we made sure that there was initial treatment available for women testing HPV, and having that treatment available at a health center level. In the past, that had not been available at that level of care. We also wanted to make sure we were ensuring that strong continuum of care and the referrals for women who might need advanced care, and then the supporting systems around sample collection, sample transport, data recording and reporting, feedback mechanisms, counter feedback mechanisms for facilities and clients were all part of the technical assistance. By the end of October 2025, we had supported the MOH to reach close to 4,000 women in Surabaya City, which was 54% of the targeted population, and over 550 women in Sidoarjo, which was about 45% of the target population. So we didn't quite reach the 75% goal, but the screening rates were significantly higher than the 4% screening rate for East Java province that was documented in 2023. So we saw significant increase in access and uptake of screening. Positivity rates for both were at 4.6, 4.3%, which were within the norm, we felt. And by the end of October, about 60% of those who had tested positive were followed up for treatment. So we feel this is still an area that needs continued support. We'd like to see higher rates of follow-up, and are continuing to work with both districts on that. So I want to share with you just a couple of key lessons learned, and then talk a little bit about next steps. I think some of the things we learned around the communication piece was that we had to go beyond messages such as screen early or prevent cancer or take control of your health. We needed to give women much clearer explanations of why HPV DNA testing was being used instead of visual inspection, which has been the norm in Indonesia for quite some time. We needed to make sure we talked about treatment options that were available. We needed to reassure that getting an HPV DNA positive result did not mean cancer. That was a really clear message we had to get out there. So when we worked with codders and we worked through a local foundation to work with those codders to educate women in the community, and they shared that information, that specific information, we saw fear decrease, we saw stigma go down, we saw trust increasing, and we saw more women accessing the screening services. So we're recommending that the community education needs to have very practical, contextual, and reassuring messages that address women's real concerns about this screening service and about cervical cancer more broadly. As I mentioned earlier, codders were absolutely critical to the success of this program. I think one of the main driving factors in women accepting screening were that codders actually screen themselves initially. They performed self-sampling on themselves so that they knew what the process was all about. They could speak to the real life situation and reassure women about it. And having them go through the process first, we think really set the stage for creating that trust with women and increasing the access and uptake. Self-sampling, but with no doubt, increased reach, increased access. We created multiple opportunities for women to test themselves. They could go to a facility, they could go to a community health post, they could go to a community meeting hall, a community venue, and meet with codders there, or they could even test at home. So there were trying to address women's needs for flexibility and convenience and privacy, offering multiple options, doing that through self-sampling. We think self-sampling can be a game changer for Indonesia in terms of scaling up access. The hub and spoke model, we feel improved efficiency. We saw that the centralized hub equipped with automated platforms could work very quickly with high volume settings, and in lower volume settings, the more manual platforms were appropriate, provided that those laboratory technicians had adequate training, refresher training, and the ongoing supervision and quality assurance. Finally, we saw that both facilities were able to adopt the models that were introduced, and they're continuing this beyond the life of the study. So we think that speaks to institutional ownership in a very big way. Through this study, we generated a number of practical resources that the ministry can use in their scale-up efforts: training materials, SOPs, educational materials, self-sampling, IEC materials, many different materials that should be helpful in the national scale-up. We also helped develop a costed operational plan to support budgeting and policy making at district level for introducing and scaling up HPV DNA testing and thermal ablation. And we're in the process of finalizing a white paper that will provide comprehensive implementation guidance for scale up. So our overall hope is that the results from this study, including these various deliverables that have been developed for guidance, will be used by the MOH to drive national scale up of HPV DNA screening through implementation of hub and spoke models, expanding self-sampling, integrating the service into JCON or the National Health Insurance Financing, really critical. I don't think I've spent enough time talking about that. Improving data interoperability to help with follow-up and the continuum of care, and supporting the MOH overall to reach its ambitious cervical cancer screening targets by 2030. And we hope to continue to play a partnership role to the MOH in achieving that vision. Thank you very much, Bunaro.
Thank you, Bu Mary Jane, for sharing with us the lessons, key messages from the study we conducted in East Java. Now we shift our focus to the technical hub of our discussion. It is a pleasure to introduce Mbak Yulia Widyasanti, a laboratory specialist at Cervical, Indonesia. Mbak Yulia brings deep technical expertise to the table, and today she will provide a comprehensive look at the laboratory perspective of our work. She will be describing the automatic versus the automatic system, and perhaps most importantly, sharing the ideal versus the facts, bridging the gap between theoretical laboratory standards and the realities we face in the field. Mbak Yulia, thanks for joining us. We look forward to your insight. Please.
Today, I would like to share my experience supporting the HPV DNA screening pilot project in East Java, particularly from laboratory quality perspective, what work, learn, and why laboratory system material implementation. In this, a laboratory system perspective to provide a comprehensive view of how quality supported the HPV DNA screening pilot project. I will briefly touch on different testing approaches, including fully automated and semi-automated systems. But more importantly, I will highlight the concept of ideal versus reality, bridging the gap between laboratory standard on paper and realities we face in the field. I will conclude with key lessons learned and consideration for strengthening laboratory quality moving forward. HPV DNA testing play a critical role in the early detection of cervical cancer. During this pilot project, I supported laboratories in Surabaya and Mojokerto, where HPV DNA testing detected high-risk HPV infection even among women who appear clinically normal. This experience reinforced an important point. Early detection only works when test results are accurate and reliable. When laboratory quality is strong, patients are protected from false results, and clinicians can trust laboratory data to make timely and appropriate decisions. That trust is essential for the success of any screening program. Although laboratory preparation was not the main focus of the pilot, laboratory readiness quickly became essential. I supported laboratories by strengthening staff skill through hands-on mentoring and improving daily workflow. This began with monitoring whether standard operating procedures were consistently followed, starting at the primary health center level, particularly during temporary sample storage before transportation to the laboratory. Improving daily workflow didn't mean adding more procedures, but making existing process clearer and more consistent. This included clarifying roles within the laboratory team, streamlining sample flow from a health center, control storage and transport, to appropriate storage and handling in the laboratory before HPV DNA testing. Simple practices such as clear sample labeling, routine temperature monitoring, and better communication among staff help reduce delays, maintain sample quality, and support accurate result. Supervision was also conducted to ensure testing was performed according to procedures, including the use of quality control materials to maintain result accuracy. Ideally, laboratory operate with smooth workflow, sufficient staff, and often fully automated or closed testing system. In reality, many laboratories operate with high workload and limited capacity using semi-automatic systems that require more manual handling. In Surabaya, laboratory operate with fully automated system. Automation help reduce variability, lower contamination risks, and support higher testing volumes with stable quality. In Mojokerto, laboratory use semi-automated system. Testing is still feasible, but manual steps, especially during pipetting and sample handling, increase variability and pressure, particularly when workload is high. Borderline result also require more human judgment. So the key takeaway here is this: technology matter, but content matter even more. Where automation is limited, maintaining quality depend on teamwork, discipline, communication, and adaptive quality management. Several important lessons emerged from this project. First, preparation is critical. Laboratory need time and support before implementation. Second, hands-on mentoring build confidence more effectively than written guidance alone. Third, quality is not a one-time checklist. It requires continuous attention. And finally, laboratory quality is a shared responsibility. It depends on people, not just systems. To close, strong laboratory systems are essential to building trustworthy screening program and ultimately healthier communities. Thank you very much for your attention. I'll now hand it over to Ibu Nurul.
Thank you, Mbak Yulia, for sharing with us the very detailed key messages on laboratory aspect of this study. So we have Dr. Indra Yul here representing the Indonesia Gynecology Oncology Association. Dr. Indra Yul has been a key figure in bridging clinical practice with national health goals. She will provide a vital perspective on the professional association role in the recent HPV-DNA pilot project. And she will also share the lesson learned from the viewpoint of the specialists on the front lines. Dr. Indra Yul, we are grateful for your time and expertise. Please share with us your insight.
Thank you, Dr. Nurul. Good morning. Yeah. I'm just a member of HOGI or INASCO, yeah, in the Cervical Precancer Relation Task Force, who assigned to assist in this pilot project. Yeah, I'm just bridging clinical practice with national health goal. Yeah, the implementation of cervical cancer screening pilot project with a hoop and spoke model using HPV DNA and cell sampling in East Java, exactly at Manukan Kulon Primary Healthcare Surabaya and Pilang Wonoayu Primary Healthcare Sidoarjo. In our role, yeah, first we educate kader Surabaya hebat and healthcare worker at primary healthcare about the importance of screening for cervical cancer prevention. Yeah, kader Surabaya hebat and healthcare worker first try it out, yeah, taking sample themselves, and then they can educate and encourage, yeah, women within the coverage age range, yeah, to get screened. For the implementation of awareness in the field, yeah, the role of the Kader Surabaya Hebat and YKI, Indonesian Cancer Foundation, is Java branch, is very important. Yeah, because they provide education and encourage women to do self-sampling DNA test. They come to provide education at PKK meeting or family welfare empowerment meeting, yeah, women's community gathering, pengajian or Islamic gathering, and also door-to-door home visit and jemput bola, yeah, to achieve the screening target according to the national action plan of the 75% of women aged 30 until 69 years old to be screened for HPV DNA test. Yeah. After the HPV DNA test result come out and the result is positive, yeah, the GP, our doctor in primary healthcare, will perform in speculo to check for deletion, or we perform VAT, yeah, VAT, yeah, visual assessment of the cervix before treatment, and we perform VIA, and then evaluate the eligibility for thermal ablation at the primary health care. From HOGI or INASCO, we train the doctor at the primary health care how to determine eligibility, how to perform documentation VIA, and then consult. Yeah, they can consult to us with tele-do-via because with the tele-do-via, if the lesson is not eligible for thermal ablation, we can advise and how to refer the patient and where best to refer them, and so the patient can be monitored like that. And then if they're eligible, they can perform at the primary health care, and if the lesion is not eligible, they have to refer. Yeah. Hoki or INASCO strongly support this program to help Indonesian women become free from cervical cancer. We are ready to assist the government and making this program success. Also POGI or Indonesian Obstetrician and Gynecology Association also has a sprint program Selamatkan Perempuan Indonesia to save Indonesian women. So let's collaborate together to save Indonesian women. It's for us. Thank you, Dr. Nurul.
So many thanks, Dr. Indrayul, for sharing with us your perspective of this study and also the role of Hogi on this work. Please, Dr. Luki, share your insight on this and please help anyone to share her slide. Yeah, please, Dr. Luki, the time is yours.
Okay, thank you, Ibu Nurul. Good morning, everyone. I'm representing Dr. Nadia. I would like to share about the cervical cancer elimination program in Indonesia. Next, just for the background, that the burden of the prevalence and incidence of cervical cancer in Indonesia quite big. With the new cases is about 36,000 and the death rate also quite high. It is because somehow the patient just come to health facility in the late stage. Next. So with this situation, Indonesia already developed the national plan for eliminating the cancer, cervical cancer, and through the collaboration with all stakeholders, we build the system and we try to setting the target to detect and to screen in the early stage among all the women in its 30 until 69 years old. And with the National Action Plan next, we also collaborate with not only for the early screening, but also implement the immunization for the HPV vaccination among the children, boys and girls. And yes, the coverage of the immunization of HPV also need to strengthen, and we also would like to implement the vaccination among the adult women, but still in the preparation right now. And for the treatment, actually, we have the target to make sure that all district at least have one hospital to treat and manage the cervical cancer. Next. Implementing the self-testing model of HPV test, it's just started in 2025. Before 2025, we using the IFA only, and then we using the provider sampling in 2023, 2024, and we start the self-testing in last year. Next. We have the vehicle. This is we call cek kesehatan gratis, means the health examination for free for all population in Indonesia, and it is included the screening for HPV DNA. Next. And this screening implement in the primary healthcare, and if we see the uptake of the HPV screening from 2023 until 2025, we achieve about 600, more than 600 thousand women screened for HPV. And if you see the trend in the monthly trend, it is quite impressive that in at least in last 3 months, it is achieved the highest population to be screened for HPV DNA. This is including method of the provider sampling as well as including the self-sampling method. Next. So we see that a lot of bottleneck we face in the field. Like for example, there is still low community participation. They afraid of being tested, and they afraid because of the stigma and cannot give themselves because they need to have the permission from the husband or the partners. And we also see that there are some obstacle in some places because the readiness of the laboratorium in their area is not yet setting up, and then they need to transfer the specimen to other district or other province. Besides that, we also aware that the supply of the reagent and also supply of the collecting kit not not ready or not enough in time, so they couldn't couldn't do the screening. And also we see that several districts said to us that they still afraid because they not yet been trained how to collect the sample. That's several obstacle that we see in the field. Next. So if we see the data showing that several impressing story about the positivity rate from the screening overall give 4% of the positivity rate of HPV DNA test, with the range of the subtype vary in several subtype of the DNA HPV. Next. So here, the cascade of the screening, the total achievement is more than 600, and the HPV positive is about 4%. And among those who have HPV positive, we make we ensure that all have IFA test, but in the achievement we only have can achieve 75% of them doing IFA test. And with the positive IFA test, it's about 500 something, and among that, who have the cryo and river still very limited. This is just showing that beside we need to strengthen the screening and the test of HPV. We need also to strengthen the referral system to make sure that all the HPV positive and IFA positive also have the good treatment and fast management of the treatment. Next. Yes, this is if we see the burden and the target, because Indonesia is a huge population, and we have the ambitious target. We see that at the end of 2030, we would like to achieve 75 women have HPV test, and of course we gradually increase the target year by year, but yes, again the achievement still very limited. So I think with the self-sampling we will try to get more easy to test the population. Next. Um, yes, the self-sampling is one of the answer and the opportunity to us to improve the uptake of the test of the HPV. Next. Yes, this is that what I would like to remind again, that this is not easy, even though the target is ambitious, but we also see this is not an easy way, because we need to strengthen the knowledge and awareness, because this is still lack in community and also maybe in medical staff as well. And also the social perspective and cultural form and fear and embarrassment, and also we need to improve the family support, because now still very low. Next. Thank you for the GHP Go and Rose to help us to starting the initiation of the sampling, self-sampling test with the support from all Surabaya and Sidoarjo and Hogi, and we see that this kind of model very feasible and very important to be scaled to other area. Next. Of course, with the participation of all stakeholder, we need to we need finance support also, to make sure that self-sampling also afford in Indonesia and in all area. Next. I think next, I think we not now we don't have any hesitance, because we also communicate with the puskesmas, we communicate with the hospital, we communicate with other stakeholder, and ask what if we use the self-sampling, is it good for us, for you or not? And mostly they said that using the self-sampling is the good one for Indonesia to improve and to capture the target. Next. Yeah, this is the last slide. Of course, we need the comprehensive strategy to implement the screening program. So I think we try to make sure that all the health staff receive the integrated training, and also we need the stakeholder engagement. We need the community uh, to support us, and also we need to speed up the system of the laboratory and the transportation system, and it is need the collaboration with all all sectors. Yeah, next, I think that's the last slide that I would like to share. Thank you. Back to you, Ibu Nurul.
Yeah.
Thank you.
Yeah, thank you, Dr. Luki, for sharing with us the challenges, the current situation, and the way we will move forward. So our final presenter will be Dr. Parak from Jipaigo. He is the technical lead for women cancer at Jipaigo. Dr. Parak joined us with a wealth of international experiences. Today, he will be sharing best practices and lessons learned from Jipaigo HPV DNA research and project across the globe. Dr. Parak, please also translate the global study into actionable insight for us in Indonesia, how what we need to do further in Indonesia to ensure that we reach our national cervical cancer elimination plan goal. Dr. Parak, please, the time is yours. Yeah.
Thank you so much. Thank you so much, Bunurul. I'm just sharing my screen and I'll keep it brief. I know we are running late, but please let me know if you can see my screen. Is it visible? I guess it's visible, Bunurul.
It is visible. It is okay, Dr.
Okay,
Parak,
great.
please.
Thank you.
Yeah.
So thanks again for this great opportunity, and thank you so much for my earlier speakers for sharing their perspectives. I'll probably, summarizing what you all have already mentioned, but first want to start with a great appreciation to Ministry of Health for their robust National Cancer Control Plan. And I think a very, very clear elimination roadmap. We saw it in the slides by Dr. Luki, and what we believe is really required in the country to achieve those elimination goals is the execution discipline, and this particular national cancer control plan actually gives that policy foundation. There are existing global benchmarks and there are existing tools which should be referred as this execution gets unfolded in the country. The best part I think in Indonesia is the ambitious goal. Like if global ecosystem is thinking about 90-70-90, in Indonesia the target is 90-75-90, which shows the ownership and readiness and willingness of the ministry. And I think the demonstrations that today got shared, or there are other partners who have also done such demonstrations. I think those in-country demonstrations are giving us real insights to drive things forward in the country. What I also want to emphasize the importance of focus on all three pillars at the same time. This is an extrapolated diagram from of the fact sheets by UNFPA, in which we can see that if we really want to avert deaths because of this preventable cause, we really have to focus on all three pillars together. For at least next 50 years, and this is Indonesia numbers, the 30% plus contribution would be because of vaccination related efforts, but 40%, almost 40% death aversion will happen because of investment into screening and precancerous lesion management. And eventually, obviously, the impact of vaccination will kick in. But, in the interim, if we really want to avert deaths because of this preventable cause, we really have to invest into screening and treatment. And probably self-sampling is the way forward, as we heard in Ministry of Health's presentation as well. We at Jopaigo have been working on these similar initiatives across multiple countries, including Philippines, where we have examples of working on urban health model in India, where we have experience of working in rural settings, and that too with cadre like cadre in the country, which is called as Ashas. In Bhutan, which is another country where, which is probably only LMIC which has moved towards elimination goals. Currently, we are trying to work with Ministry on quality assurance mechanisms. And there are other examples from Africa and other Asia and Pacific countries. But what I really want to bring to today's conversation is these 6 important points. What are the 6 key learnings that we will like to propose, and I like to propose for today's session is the first one, which I think many speakers also referred to: the behavior change communication, and clear and culturally appropriate messaging, not only on cervical cancer, but specifically on HPV infection and the follow-up care is an absolutely important element. Because what we have observed across multiple countries that women do prefer, let's say self-sampling, but where essentially things get faltered is the follow-up behavior. And the major service that we will be doing is to ensure that that loss to follow-up is avoided. And I think there the behavior change or social behavior change communication is very important. Second is, how do we anchor this entire programming on primary healthcare setup, right? And that has been the learning, let's say specifically in India, where we really invested into the role of Ashas, which is parallel to cadres in Indonesia, right? So I think their role is very important in demand generation, in supporting self-sampling, and also the continuity of care. Another important lesson, and I think I like to appreciate what has happened in Surabaya and Sidoarjo, wherein there is a clear-cut emphasis on the fact that there is no one model for the country. And Indonesia is so diverse, populous country, so we have to have those context-specific models. And that has been our learning also across other countries, where there is no single national approach, which will really move us towards the elimination targets. Next one is continuum of care and quality assurance. My colleague also mentioned the importance of quality assurance in lab settings, because what we have observed that if we do all the hard work and get sample to the laboratory, but if things are not stabilized or not monitored or validated in the laboratory, there would be, those would be a futile efforts in the first place. So that quality assurance and continuum of care is something which is absolutely non-negotiable. On leveraging mixed health systems. So we have Bhogi representatives here, and I again want to mention for settings like ours where there is a mixed health system, I think identifying those private providers, those champions, identifying those laboratory systems which can complement our public systems is crucial. And I think in today's panel composition also we see that we have representation from multiple sectors. And finally, one important point, which again comes up when we talk about any vertical programming, is integration. So we really have to move away from vertical programming to integrated efforts, because that can really amplify and multiply our impact and efficiency. And with respect to HPV programming, I think the integration opportunities are across HPV vaccination, across HIV platforms, across NCD services, or even for women's cancers for that matter. Like, how do we ensure that women in the eligible age group get screened not only for cervical cancer, but also for breast cancers? And with these some key insights, I would like to pause for now, but really want to appreciate and thank for this wonderful opportunity. Over to you, Bunurul.
Yeah, thank you very much, Dr. Farah, for sharing with us the global perspective and how Indonesia can move further. Now, the time for us to have the question from the audience. I don't see many, but one of the question is about if there is any study comparing the efficiency between the IFA test and the HPV DNA. I don't know if any of you can share with us, Dr. Parak, maybe if you hear any study from the global about a comparison about the IFA test, the visual inspection using acetic acid with the HPV DNA, as we now move to the HPV DNA testing. If you have that otherwise, yeah, please, Dr. Parak, if you know, or maybe Dr.
Yeah.
Indrayul.
No, absolutely. Yeah, maybe I'll
Yeah.
request Dr. Indranil also to add, but just to quickly reflect upon that. So there are a lot of studies in different settings, which have clearly mentioned and clearly states the improved sensitivity and specificity of HPV as against VIA.
Okay.
In fact, there are studies on its better performance or better accuracy even in comparison to cytology. So
Okay.
I think, and that's why it has been chosen as the preferred high performance modality for screening. Maybe
Yeah.
Dr. Indra, if
Yeah.
you want to add a bit.
Yes. Thank you, Dr. Parak. I believe that we can further ask you to and we can also search on.
Thank you, Bu Nurul.
Yeah.
As we know, our primary screening program in Indonesia at 2015 is VIA test, yeah, as a primary screening program for cervical cancer. It's very cheap. We just need acetic acid. It's also very cheap. But this examination is need competency, yeah. I think just maybe health worker or midwife or doctor who can perform this VIA test and can this is positive or no. Sometimes then not sure, maybe in doubt. So Prof. Laila Nurana from Jakarta, she introduced about the dokumentasi VIA. So now we can take a picture, for the VIA. For VIA, this is positive or negative, and we can also perform tele dokumentasi VIA to know this is positive or negative. But as we know, the sensitivity and specificity is not high. It's very subjective. So from WHO use the SPV DNA test as a primary screening test for the woman at 35 and 45, just twice. But in our country, the coverage is very high, 75% for age at 30 until 69. So
Yeah.
if the coverage is so high, so we have to help,
Yeah.
to make a
Of
success
course.
this program, so we can also save the women for free for cervical cancer. I think like that.
Yeah, so many thanks, Dr. Indrayul. We have limited time, 1 minute, time's up, but maybe we can answer one another question. I believe Bu Mary Jane will answer the question. Please, Bu Mary Jane.
Yeah, thank you, Gunarul. I see the question is about how women receive the results. So just wanted to share that all results were printed and shared with women in sealed envelopes, whether they were positive results or negative results, given to cotters to distribute back to those women. And then there was follow-up from the clinicians at the health center at the Puskesmas for those women who had tested positive for the follow-up actions and bringing them back in for care. Back to you, Gunarul.
Yeah, thank you, Bu Mary Jane. Our time is up, but let me close this session today. One thing is clear that cervical cancer elimination in Indonesia is no longer a distant dream. It is a tangible goal. Today we've heard HPV DNA self-sampling is more than just a medical tool. It is an instrument of empowerment. By integrating this innovation into the ILP vision, we aren't just improving system efficiency or lab quality, we are reaching the mothers, sisters, and daughters who previously felt the healthcare system was out of reach. A huge thank to you, to our incredible panelists for sharing the insight from East Java and outlining the roadmap for national scale-up. Your expertise remind us that while the technology is groundbreaking, it is the collaboration between policy leaders, healthcare workers, and the community that will truly strengthen our health system. Also, thank very much to the audience for your insightful question and your engagement. But the conversation doesn't have to end here. You can don't hesitate to put your further comment, and also we put in the slide the email address of us if you have a further question. And also we will, for your information, we will have national dissemination meeting to share the whole study result. And of course, we will have the full report of this implementation research. And also, please share this stream with your professional network to help spread awareness about the safe 2-HSPV DNA testing. And if you are a healthcare provider or policy advocate, we encourage you to look at how this model can be adapted in your own region. So together, we can ensure that no woman in Indonesia is left behind in our fight against cervical cancer. Thank you for joining us. Stay healthy, and we look forward to continuing this journey with you all. Sampai jumpa and have a productive day. Terima kasih.